Good evening and welcome to the guests to this OBI Public Talk. My name is Tom Mickelson. I'm the President and Scientific Director of the Ontario Brain Institute, or OBI. We're a provincially funded, non-for-profit. We're an organization that sort of attempts to accelerate discovery and innovation, benefiting patients and the economy. We sort of champion the idea of team science as an approach to brain research, commercialization, with the intent of bringing data towards care. We try to connect researchers, clinicians, industry, patients, and their advocates to improve the lives of those living with brain disorders. The purpose of events like our Public Talk series is to shed light on some of the complex issues surrounding brain disorders, to fight stigma, and to provide knowledge, and stimulate our own brains, and challenge ourselves to continue learning. Pain in children, the subject for tonight, of course, is really a misunderstood, underdiagnosed, and underdiscussed issue, and probably undertreated in the population. This is even a bigger issue for kids living with disabilities. Until the 80s, it was even thought that babies didn't feel pain. Thankfully, research has dispelled this myth, and our knowledge of pain has undergone a rather dramatic revolution, but management practices have not yet changed and is often an afterthought, especially in kids. The lack of specific management strategies force children to cope, even when relatively straightforward, workable techniques can minimize their trauma, their anxiety, and their quality of life. We must take pain seriously and actively incorporate pain relief as a pillar to practice in the healthcare system. We don't have to let the kids suffer in silence. We're proud to partner with organizations like TVO, TV Ontario, in our Public Talk series. And tonight's talk is being live streamed on tvo.org. This event, by the way, is being photographed and videographed, so do make sure you take note of that. A video of the talk can be made available on our website. We encourage you to share it with others and stay tuned for other talks in this series. You can subscribe to our newsletter online, and you can also tweet about this talk at #TalkBrain and #ItDoesn'tHaveToHurt. So, enough about me. The quick introductions for speakers and moderator tonight get the program rolling. And after our speakers are finished, there'll be a moderated Q&A. And during the talks, you can actually forward your questions by direct tweeting to @OntarioBrain. And I think that's meant to be right there. So, our speakers tonight are Dr. Christine Chambers, who is a Canada Research Chair in Children's Pain and Killam Professor in the Departments of Pediatrics and Psychology and Neuroscience at Dalhousie University. She's the Scientific Director of Solutions for Kids in Pain, which you'll hear a lot more about shortly. She's published over 155 peer-reviewed articles on the role of developmental, psychological, and social influences on children's pain, with a current research focus on the role of families in pediatric pain, patient engagement, and partnerships for knowledge mobilization. Dr. Darcy Fehlings is a senior scientist at the Bloorview Research Institute and is an expert developmental pediatrician and scientist. She's also part of our OBI program called CPNet and a member of the Solution for Kids in Pain network. Dr. Fehlings has made unparalleled contributions and advancements in the field of developmental pediatrics, from student mentorship to establishing an international evidence-formed network to make real and meaningful impact on the lives of children and families dealing with cerebral palsy. Most importantly, Julian and Donna Cappelli this evening. Donna, the mom, and Julian, aged 18, is a family with a story to tell. Julian was born with a severe form of cerebral palsy, which allows him little control of his body and struggles with constant pain. Every time he has a growth spurt, he's had to go through weeks and months of tight muscles and physical therapy. Despite these uncontrolled movements and the pain, though, he speaks with passion and is an extremely bright, happy, and funny young man. Also a bit of a ham on the television, I understand. He's a high achiever and loves to read. And the one thing he wants people to know is that it's okay to be different. Our moderator tonight really needs no introduction. Audrey Picard is an award-winning health journalist who's been with the Globe and Mail for over 20 years, best-selling author, renowned speaker, and an advocate for improving the health of Canadians. He's received many awards and was also named Canada's first public health hero by the Canadian Public Health Association and a champion of mental health by the Canadian Alliance on Mental Illness and Mental Health. There was a terrific expose or interview with him on healthydebate.ca that I saw today. It was just a brilliant review. So we're going to kick off the program with Dr. Christine Chambers, and as I said, the speakers will come up afterwards, but there will be a moderated discussion towards the end. And again, live tweet if you know how to do that, because I don't, but there it is. Dr. Christine Chambers, join me in welcoming her.
Wonderful. Thank you all so much for joining us tonight, and thank you to OBI for hosting this event. So we're here to talk about children's pain. We know that children experience pain from a variety of sources, from medical procedures to surgery to pain associated with chronic disease. We often think about chronic pain as an adult problem, but we know that 1 in 5 children also experiences chronic pain. And children with disabilities are especially at risk for pain. Canada is a world leader in children's pain research, and my own research over the last 25 years has focused on the role of parents in children's pain. And in this slide, you can see while it's the baby getting the needle, it's the father who is feeling the child's pain. And my research has very much over the last 20 years focused on what parents say and do and how that impacts their children's pain. The way that science works is that we researchers, we write grants, we write a lot of grants, and sometimes we get them. We conduct studies, we publish our findings in scientific journals, we present them at medical conferences and science conferences. And that's the circle of science. Then you get your next grant, and you do your next study, and you publish your next paper. But every pain research grant or every research grant I've ever written and I've ever reviewed always begins and ends with a promise that the proposed research will at some point benefit patients. But the way that science works doesn't automatically make that happen. We've made incredible gains in our generation of new scientific knowledge, not just in pain, but in science at large. And an average of 2.5 million scientific articles are published each year. And it's estimated that our global scientific output is doubling every 9 years. Various estimates show that it can take as long as 17 years for research findings to be adopted into practice. And if you think about it, it's a huge volume of science that needs to get disseminated. We know that only about 14% of clinical research ever actually makes it to the front line to benefit children and families. And if you think about that 17-year estimate, I mean, that's a whole childhood, a whole generation of kids who miss out on benefiting from the science that we already know. As Tom mentioned, as recent as the 1970s and 80s, it was widely believed that babies, especially premature babies, didn't feel pain, or that it was too risky to use anesthetics with them. So babies were given paralytics for pain so they wouldn't move, even during very invasive procedures and surgery. We've certainly come a long way when it comes to pain management in children, but there are still many ways that we're failing children and their families when it comes to pain. One study led by Dr. Bonnie Stevens from Sick Kids, who's here this evening, showed that hospitalized children experience on average 6 painful procedures every 24 hours. And only 2/3 of these procedures, or over 2/3, are done without any pain management at all, even though we have effective solutions that run across pharmacological, psychological, and physical strategies. And we know from science that managing pain in kids is not just a nice thing to do. Poorly managed pain has a long-term impact on children's brains and children's bodies. So 5 years ago, I decided I wanted to reach parents directly with evidence-based information about pain. We created a brief YouTube video for parents and tried to push it out to as many parents as we could. But I learned a really important lesson while doing this, which is if you build it, they do not necessarily come. We researchers and health professionals have a very limited reach in terms of our ability to engage and ensure that all of this great knowledge gets to the people who can use it. So when I ran out of email listservs, because that's how scientists communicate with one another, I started tweeting. And I very quickly learned that if I could engage influencers, people, journalists like Andre Picard, or parenting media, I had targeted Erica M's YummyMummyClub.ca, which has a reach of over 6 million Canadian mums a month. When I could engage those types of influencers to share my messages, we had greater uptake, and we could track this just by watching the video count on YouTube. And that gave me an idea, which is, why am I, a scientist, spending my time trying to create parent-friendly content, trying to get it in front of people, when there are people who have this expertise and do it every day? So the idea of a partnership came into my mind. I can bring the science and the scientists. Could I work with Erica, for example, and her team to package that, literally translate it into content and engage with Canadian parents about it? So I reached out to Erica with the idea that we write a grant, and she was like, "What's a grant?" So I explained it to her, and we were very fortunate to be funded by the Canadian Institutes of Health Research to create a 12-month program called It Doesn't Have to Hurt. What we did was use a branded content campaign, a concept from marketing, and what we did was gather all the science that we have in the medical journals. We had parents guide us around what they wanted to know. The researchers synthesized the evidence, and YMC turned that into compelling digital content and pushed it out over their network of Canadian influencers. These are some examples of the blog posts that would appear on the YMC site, many written by parents, and our goal was to seamlessly embed research-based information about pain with parent storytelling. So many of these blog posts were written by parents. Some of my favorite content were the Instagram images. And again, this one, breastfeeding and needles equals it doesn't have to hurt. That image in 3 words summarizes dozens of randomized control trials that have been published in journals, synthesized into systematic reviews. But at the end of the day, what's the take-home message for a parent? Breastfeeding and needles equals it doesn't have to hurt. Our Twitter parties were very popular. These provided an opportunity for parents to engage online directly with scientists and ask them questions. These were so successful in generating traffic to linked resources that we once crashed a hospital server, directing so many parents to a pain assessment tool they didn't even know existed. We trended #1 on social media on a number of occasions, which for someone who's been trying to get people to talk about children's pain for 25 years was so gratifying. So the power and experience of this partnership has led us to Solutions for Kids in Pain, or SKIP. This is a newly funded Networks of Centers of Excellence Knowledge Mobilization Initiative, which is essentially a scale-up of our partnership model that we pursued with It Doesn't Have to Hurt that works so well for parents, but is intended to engage all the knowledge users in the system. So not just parents, but patients themselves, health professionals, policymakers, and the public at large. SKIP is co-directed by myself, based at Dalhousie University, and Doug Maynard, who's here tonight from Children's Healthcare Canada, based in Ottawa. And together, we're bringing together those who produce the knowledge, so those would be the scientists and researchers, with 48 different health institutions from across Canada, including all the children's hospitals, Holland Bloorview, Sick Kids, and we have 4 regional hubs who we're engaging. The way that our approach works is we have these regional hubs, again, from Halifax, Ottawa, one at Sick Kids led by Fiona Campbell and Bonnie Stevens, who are here this evening, and also Stollery Children's. And what's really unique is our partnerships, and really we have layers of partnerships upon partnerships. Patients play a key role in all of our activities. This isn't just for patients. SKIP is done with patients. They're engaged at all levels, including management and governance. And our bringing together of over 100 different partners from across Canada and around the world, many of whom have representatives here this evening, brings together expertise, technology, and resources from outside of health. Our 4 main activities include things like readiness, resources, and evidence. We've done a needs assessment, and I will say that the needs of children with disabilities as they relate to pain is one of the top priority areas. We'll be producing new tools and promoting them, including a new hospital accreditation standard with Health Standards Organization. We will be facilitating change, working directly with institutions to help promote implementation of evidence. And then we'll be working to increase public awareness and create a sense of urgency around the importance of pain in children, including events like this one here tonight. So I love a saying from Helen Keller, who once said, "Alone we can do so little, together we can do so much." By bringing everyone together, we hope SKIP can be a game changer for children with pain. We all have a role to play in ensuring our children receive evidence-based pain management. And we also hope that the innovative partnered knowledge mobilization activities we're offering through SKIP could serve as a model of change in other health areas as well. So thank you, and I am going to encourage you all to please continue to tweet, send your questions in, and next we will have a video.
I'm Donna, and I am Julian's mom. Julian is 19 years old, and he was born with cerebral palsy, which means that he's had damage to a part of his brain, but he also has dystonia as part of it, which is uncontrolled twisting movements, which attributes to a lot of his pain. Can you tell us a little bit about your pain? Your muscle spasms? Sometimes it's every minute of the day. Now I'm gonna cry. 24 hours, 7 days a week. How does the pain impact how you're feeling? It depends on the day. Yes, we're laughing because this is like probably the basis of our fights all the time, because he gets really frustrated, and I understand he gets frustrated, but he yells at me. And sometimes he can be quite rude. And it's not my fault, and I understand his pain, and I always say to him, it's okay to yell. However, could you not be so personal about it? Yeah, exactly. Be so rude, exactly, yes. So it's good that you can laugh about it. It wasn't funny at the time, but
yeah, no.
Yeah. Yeah. So he's always had growth spurts, but it used to be like once maybe 3 times a year, he'd have like 2 or 3 periods of 3 weeks at a time. And we would know that it would like end after about 3 weeks. This year, it went on for about
3 months.
I feel like it was even longer, maybe 4 months of just like 3 months. And so, you know, he was getting the teacher to call me every day from school. I was picking him up from school. He wasn't making it to the classes. He wouldn't be able to go out. Like, we did not like leave the house on weekends. He wasn't interested in going out, being social or anything. And even like taking part in after school activities became quite a bit of a struggle for him. Pain is just like all encompassing. Like, it takes over like some weekends. Like, our house is just like this vortex. Like, you know, he just kind of like, he wallows and he just like sucks us all into this, like, you know, and we feel like, oh my God, we've done it again. We know that this is what we're trying to avoid, and we've done it again. We've kind of allowed ourselves to kind of get, you know, all engulfed in this without taking all of those necessary steps that we know to like back out and say, okay, what do you need? Let's, you know. And you know what, to be honest, I think I've been cruising until about this last episode of pain, like this last 4 to 5 month one. This one I really had a hard time. Up until now, I really thought I was like a superwoman. I'm working 2 jobs, I'm taking care of Julian, I'm doing his appointments, I'm staying on top of it, and through it all, I'm staying positive. But this last bout, I felt like that constant every day seeing him struggle was a lot. And it wasn't until maybe 2 or 3 weeks ago that I kind of like really lost it at home, just kind of got really upset. And my husband's like, I'm okay with you taking time. You just have to tell me what you want to do, and you do it. So if it means that on the weekends you need to go and take a couple hours and go work out or go do something. And so literally it's been 2 weeks of us kind of like trying to find a new way to manage this, to say, okay, I have to walk away. Because like I said, up until now, I feel like I felt like it's almost like I have failed Julian if I'm going to fall apart too. So I don't allow myself to, I don't give myself the time to, I'm just going to keep doing everything that I need to do. But I realize that's not really healthy. And I can't keep myself mentally strong for him if I'm not mentally strong. Well, we have seasons passes to soccer, and then last year that was the same thing that kind of happened. Was he was like really nervous about going to watch soccer because he gets so excited that he gets into a lot of pain, and so he kept on saying, no, I don't think I can do it. So this year we've kind of like, we have seasons passes, so we said you can go with Dad and you can just watch half of it and leave, like it doesn't matter, right? Like we have the tickets, just watch whatever you can, and if you can stay, then you stay, right? But it's too bad because he missed out on a lot of games last year because of his pain. One of the things that people don't realize is that while they're suffering, we're suffering. I'm sorry, Jules, I know. I promise. I promise. Okay. Okay, yeah. Okay, get it together. Okay. So, when Julian suffers, I suffer, our whole family suffers, and we find it really difficult to manage. And I think it's important that the clinicians, even for the children, realize that, and they have resources for the parents to go to too. What have you found helpful in managing your pain? Mindful meditation. Yeah, so maybe about 6 months ago, we got a referral to a psychiatrist here at Holland Bloorview, and she just kind of mentioned, to help with your anxiety, and it was kind of like his sleep. She's like, he kept waking up, he said he kept waking up at night and then he would be in pain and he couldn't fall back asleep. And she said, well, one of the things you should practice is mindful meditation. And she didn't really go much further than that. She just kind of said it. And then I kind of just looked up some articles on it, and me and Julian talked about it, read some stuff about it. And at first, when we came out of the appointment, I said, did you hear what she said? She said, you should try mindful meditation. He's like, that's not going to work. And then the first night he tried it, he woke up the next morning, he's like, wow, that really helped. And I said, well, why don't we take this and use it during the day too? And so very often, we kind of use that when he's really suffering. And lots of times the teachers at school will say, oh, I think he fell asleep. And I'm like, no, he didn't fall asleep. He was just mindfully meditating and trying to calm himself down and so that helps with his pain. This is the one thing that only he can do for himself. I can't do it for him. We have issues with him having a disability that somebody's always doing something for him, and that affects the way you feel about yourself. And I think by having that ability to be able to calm himself down, he can feel a little bit more successful and he feels a little bit more in control. Yeah, you feel like you're a little bit more in control of it, right? And that, I think, would affect anybody who's in pain, right? Because they feel like they're out of control when they are in pain. Don't wallow in your pain. So I think that has a lot to do with his kind of mindfulness, in that a lot has to do with attitude. When Julian is struggling with pain, we have discovered that a lot of it also has to do with prevention. So yes, so prevention is kind of for him anyways, it's key. I know that we're not talking about pain with other types of diseases and stuff, but for him, it's prevention. And so we do a lot to manage it. So if we manage his anxiety, we can manage pain. So either we manage his anxiety through medication, through having calm environment, through mindful meditation, then we can help to manage it. We try to manage it by environmental things, like keeping his environment cool, that he's not too hot, that he doesn't get overstimulated, that he doesn't get overly excitable, and all those things contribute to his pain. So my take-home message would be that for parents, I think, is to share with your healthcare providers what works, because I think that if our healthcare providers know what has worked for me, then they can even do it as a suggestion, not necessarily as a referral, but say, hey, you know what? how about you speak to this parent because they've tried some things that may help. And I would have loved that connection with somebody to say, yeah, I'll try the same things. I think that something like this, where there's a forum to talk about pain, and especially in the disability community, because there's a lot of stuff out there for kind of like pain associated with disease, like specific diseases and how to manage it. But this is just like constant, it's chronic, it's a roller coaster, and it's not going to change. It's not going to get better. And so we have to have ways of dealing with that. So if we bring this to the forefront and have people talk about it, have clinicians talk about it, then I think that this will help with their understanding of how to deal with it, and also be able to figure out more solutions for us as parents.
It's quite the video, Julian and Donna, pretty spectacular. I wanted to start off my part of the talk today by saying, go Leafs, go. So I really would like to thank the Ontario Brain Institute for hosting this public talk on pain in children. I think it's so important. And I also think both Julian and Donna are pretty amazing, and really want to thank them for their bravery in sharing their stories. So we're focusing a little bit on cerebral palsy tonight, and cerebral palsy is the most common cause of childhood physical disability, prevalence of about 1 in 500 children. And pain in children with physical and neurodevelopmental disabilities is more common than we ever expected. It's also frequently missed by clinicians, and their caregivers are also not aware. In research that we published, we identified that 55% of children with cerebral palsy had experienced pain in the last 2 weeks, and that 25% of them reported that they were in moderate to severe pain that was restricting their activities and participation in things that they liked to do. And this result really surprised us. We paired these interviews with physician assessments to make a diagnosis for the pain. And what we found was that there were some common causes of pain in cerebral palsy that were really situated in this moderate to severe pain level. And one of them was a cause called dystonia. And dystonia is a message of increased stiffness from the brain to the muscles that causes the kids to get stuck in postures. And this awareness that dystonia is causing pain, again, is something that is relatively new and we're paying more attention to. We also identified that problems with the hips was causing kids pain. And so these became 2 things that we could potentially focus on. So we found in this study that many kids just didn't have one cause for pain, that there were multiple causes for pain. And that makes things a little bit more challenging to figure out. So you're not just searching for the one cause, you have to figure out what you think is the primary one, but you also have to look for a few other things. And I think this multiple causes of pain contributes to some of the missed diagnoses that we make. But there's other factors that contribute. So sometimes children with cerebral palsy have difficulty communicating that they're in pain. I also think that they have been experiencing chronic pain, and so they don't think it's atypical for them. And so again, it's not something that they're continually bringing up to their caregivers. If your muscles are always feeling stiff, you just think this is part of the way things are. It's also important to note that for some of the causes of pain in cerebral palsy, such as dystonia, we don't have perfect treatments. And so in spite of best treatment, pain can persist and you get into a chronic pain scenario. We recently published a study that found that over time, on average 2 years, over half the children that were in the study had constant or worsening pain. Now, why is chronic pain important in children and in children with cerebral palsy? We know from our research and others that the presence of chronic pain is the most significant contributor to a negative quality of life across all aspects of the person's life. It also, importantly, has been shown to restrict participation. So when you're in chronic pain, you tend to stay at home, you don't do activities, and what happens at a brain level is you start to focus a bit more on the pain because you're just lying there thinking about pain. I like Julian's message about don't wallow in pain, and it's certainly one of the strategies that we like to carry forward. The other thing with pain, when we look at how the brain processes pain, we have a pathway that leads to a sensory phenomena of pain, but we also have a pathway that leads to an emotional response to pain. So when you're in chronic pain, you can start to feel down and sad and anxious. The other thing we saw listening to Donna and Julian talk is that if you have a child in your family that is in pain, it really has an impact on the whole family. So really highlights the need for child and family-centered care. So we're discovering more things about the brain, and some of them are really fascinating. So on a good side, we know that our brain can be plastic. It can respond to things in our environment. But you can also have maladaptive plasticity. And what we're finding is that when you have chronic pain, it can change your brain. And we call this a neuroplastic response. So the brain is reacting to something, and in this case, pain. So this slide just depicts some of the mechanisms that the brain change can happen when you have chronic pain. So one of the interesting phenomena here, and again, this has been relatively recent knowledge, that when you have chronic pain, the brain can respond by developing a hyperalgesic response. So the pain that we might experience if we had chronic pain is heightened in perception. And through translational neuroscience networks, we're starting to understand the multiple mechanisms that can lead to this. So for these reasons, we really need a multi-pronged approach to managing pain in children with disabilities such as cerebral palsy. So there's many strategies that can be implemented. One of the strategies that we have done is the creation of care pathways to help guide clinicians in evidence-informed care. And we have created these care pathways in partnership with the American Academy for Cerebral Palsy and Developmental Medicine, because I've been integrally involved in this care pathway process. We pushed forward a dystonia care pathway and a hip surveillance care pathway, because we knew we had identified these as two of the commonest causes of moderate to severe pain in children with cerebral palsy. These pathways are available online. I was talking with somebody in the audience earlier today, and for parents in the audience, all you need to do is Google AACPDM care pathway, and you can go and get some information on evidence-informed management for dystonia and hips. So another strategy, we need to teach clinicians, physicians, therapists, nurses, any healthcare professionals to routinely screen for the presence of pain. This sounds very basic, but something this basic can really start to make a difference. I think as clinicians, we're missing pain a lot. And we already know that the caregivers aren't aware of the pain. And so by having a screening question that asks this question, I think is really important. We're all moving towards electronic health records, and I have a little subplot to try to get a pain screening question as a mandatory question in every clinical encounter, so that the clinician needs to ask that before they're allowed to go on and ask other questions in the electronic health record. Another example of how to move things forward is utilizing evidence to care. We have an evidence to care unit at Holland Bloorview. They did a great job of creating a pain toolbox and have published it and distributed this information internationally. We have a role to play in teaching individuals with disabilities and their caregivers about pain and to bring up the subject of pain to their healthcare workers. So wouldn't it be great to empower parents to say to their doctor, hey, can we talk about pain today? There are not easy solutions for managing chronic pain, but you often need to develop multiple different strategies. And we've developed this pain framework called ADOPT, where assessment, so assessing for pain, demystification, talking to the individual and the family member to teach about the pain, optimizing health, and we've already talked about there's multiple things that we often need to manage, and then promoting wellness, both physical wellness and psychological wellness. And then T is for treating pain. And we can use medications to treat pain, but we can also use cognitive behavioral strategies and mindfulness approaches. Many of these strategies that I've listed are ideal for knowledge mobilization, and I'm very excited about SCIP. So we also need to focus on research to develop new treatments and evaluate their effectiveness. And as a clinician scientist, I really believe strongly in the need for research. And here I'm going to share a brief video clip of one of our most fun research projects. So we all know kids like to play video games. And so we've developed an exercise game, a stationary bicycle, where the children need to pedal the bicycle to power the avatar in the game. We've made them multiplayer. I see some parents smiling in the audience, particularly if you're a parent of a boy, because we're all thinking, how can we limit video games for our kids? But this is a reverse scenario where we're trying to use the video games to promote wellness. So there they are cycling and they're playing together. And in this particular project, we're introducing it in the inpatient rehab unit for children post-orthopedic surgery that have a lot of pain in their legs. And we think that cycling can help to improve the pain. So we're trying to test that. This particular project is being led by a master's student, and he's in the audience.
Get him, get him, get him.
And we've had one quote from one of our children that I like to say, hey, cycling and playing these games helps me to forget about my knee pain. So this is one cool, fun strategy that we can utilize. And if you want to hear more, please talk with Annalisa. Annalisa, I think you're in the audience. There we go. She'll be at the back at the booth, and she can tell you more about it. So we're very appreciative of the Ontario Brain Institute for funding a large translational neuroscience network called CPNet, and I'm privileged to be the scientific lead for that. And if you want to hear more about our approaches to pain or some of our studies after the talk, please come to the Holland Bloorview booth. Thank you so much, and I look forward to the ongoing discussion. Thank you.
Great, so thank you all for being there. I'm Andre Picard, and I'm going to lead a short question period. And remember, you can tweet your questions on Twitter. I was following the Twitter feed. I have some questions from you already. And if you don't have Twitter, raise your hand. We have a couple of ushers, and they'll take down written questions, but we don't have the capacity for mics in the room. So I want to start with a question for the real expert on our panel, Julian. You heard from all the professionals about pain and how we don't take it seriously. I'm interested, Julian, in what works for you. You talked a little about mindfulness in your video, but what else works for you for pain relief?
Did you hear his question? He wanted to know what else works for your pain other than mindfulness.
Physio. We do a form of needle that goes directly in the muscle, and just work it and get them.
So he said massage therapy, physio, and we do like a form of, it's almost like acupuncture, but it's like dry needling that goes directly into the muscles, and stretching.
And stretching.
Yeah.
What about, he's a young man, what about medical marijuana? Does that fit in the...
Yeah, so actually we got a referral from Dr. Fehlings at the end of last year, and Julian's been on it for a few months. Julian, how do you feel that the medical marijuana works for you?
When I sleep, but it's okay. It depends on the day.
So we find for Julian's pain, so the medical marijuana, he says, works really great for his sleep, but it depends on the day. So when Julian's really suffering, this is the sad part, is when it's really, really hard, nothing seems to work. Yes. When he's... Yeah. So when he's calm, it really helps, but when he's really tight, then it doesn't help at all.
And what form does he take it in?
He takes it in the oil.
Oral form, okay. Yeah. Now, Donna, in the video, you got choked up a bit. You talked about, this affects parents as well. So what do you do? There's different kinds of pain. There's not just physical pain. There's kind of the psychological pain that the parent feels. What do you do to treat that?
Other than go in a closet and cry? You know what? I haven't really kind of figured out that yet. I do exercise a bit, so I have found that sometimes if I can just take some time to exercise, sometimes when everybody leaves the house, I sing really loud to myself. I find that it's almost like screaming, because you're just like being really loud to kind of get that, anxiety out of you. And so, it's unfortunate because that means when Julian suffers, I almost need to walk away, which isn't really fair to him. But sometimes, like he says, when it's really, really bad, we're limited what we can do for him. And sometimes he actually says, don't touch me, like he doesn't even want it. We can't figure it out. Yeah, that's right. Thanks for backing me up.
But taking care of you is important too, the parent, we can't forget.
Yeah.
Now, Christine, I want to turn to you. One of the things you said in your talk struck me, so of course I tweeted it. You said 2/3 of procedures are done on children with no pain management. That seems unthinkable to me.
Right, so that's what sadly the research shows. So that study was led by Bonnie Stevens and was a survey of a number of children's hospitals across Canada. And, it's just a good example, an unfortunate example of where we really do have effective evidence-based solutions for procedure pain, but they aren't always implemented.
And why not? Is it an attitude, suck it up? Is that the idea, or what's the problem?
Yeah, I think it's complicated, right? I think we're just hitting a tipping point with our understanding and attitudes about pain. I think a lot of people just accept that pain is part of being sick, or that pain is part of having surgery or being in the hospital. I think there is still the belief that, these are just, quick procedures, they're over quickly, toughen up and get it over with. I also think, often we're just busy, people have been trained a particular way, and it sometimes is hard to change the way that we do things. So there's not any one reason why, it's a combination of factors, and certainly, the work that we've tried to do around parents to date is to really empower and engage parents, because parents are there for the majority of times that their children have procedures or have other types of pain. But we know that it's not fair to send parents into a system that hasn't had attempts at change throughout. And so that's really what we're going to be trying to do with SKIP, is to promote change from both the bottom up with patients and caregivers and the top down in terms of making it an expectation.
And Darcy, you talked about that as well. You said that clinicians, it's just not on the checklist for a lot of them. How do you change that?
I think it requires a culture shift, but I think that we're starting to get there. I'm starting to see a tipping point happen. So there's a lot more interest in pain. There's definitely a lot of awareness. An example, at our hospital, when we identified that first study that I talked about, where we had a quarter of children that had moderate to severe pain, there was a lot of momentum, and our evidence to care unit developed this pain toolbox, and we did a lot of quality improvement activities to embed that pain question into our clinical encounters. So we're really starting to see a shift. In my clinic, the therapists, when they're reporting, always say, pain, no pain, and parents and children are routinely asked. So we're starting to get there.
But you said something in your talk that I also found paradoxical, in that you said, if kids are brought up, they're always in pain, they don't know that that's not the norm, right?
And it's such an interesting thing to think about. So I remember I was speaking at a conference, and it was with the Cerebral Palsy Foundation, and the CEO of the CP Foundation has an 18-year-old with cerebral palsy. And he went home after he'd heard me speak, and he said to his son, "Tom, are you in pain?" And he goes, because he didn't think his son was in pain. And he said, "Yes, I have pain every day. My muscles hurt me every day. It's part of my life." And so I think there is this awareness, and Donna, you were mentioning it a little bit yesterday, that until we sort of asked that pain question as part of our research study, you hadn't really thought about.
No, we were kind of like, we had so many things to deal with Julian, with his muscle spasms and with his therapy. And then one day, a resident walks in and says, "Hey, I'd like to take part, have you involved in this pain questionnaire." I'm like, "Pain? Julian's not in pain." And then I start asking him the questions. I'm like, "Geez, how did I miss this?" So yeah, I think that even as parents, we're there every day. He was crying and he wasn't very verbal, so we didn't know. But he could answer yes and no questions, and he definitely verbalized that he was in pain.
And when you had that epiphany, oh my God, he's in pain, how did it change things? How did it change things for your interactions with Julian?
Well, certainly it caused a little bit more anxiety, because now you realize, you used to think, when he was crying, children cry. But now every single time he cried, you would be like, "Are you in pain? Is there something wrong? Is there something wrong?" And if we couldn't deal with it, then it just kind of made us more anxious. And sometimes I think that made him more anxious too. So I think this whole thing about calming us all down and, saying that, what your attitude towards pain makes a big difference, and the attitude of the people around you with pain makes a big difference too. Right in the wings there, while we were waiting, Julian was having this really bad episode, and he's like, "I know I look like I'm in a lot of pain, but I'm having fun." And so I think he just didn't want me to get stressed out about it, because I'm sitting there going, "Can I help you? Is there something wrong?" But he's just trying to calm me down. I'm trying to calm him down, and yeah.
Now we have an audience question for Julian. He mentioned some of his methods, massage and acupuncture and physio. There's a question wondering if music therapy is helpful.
We could talk about Bruno Mars, Julian.
No, not really.
What's that?
No, not really.
He's saying no, not really.
Nobody. that has to do with the physical movement of the body.
So he finds that therapies that actually involve touching his body tends to help more. However, having said that, I mean, I think his dad does like music therapy at home with him, like, you know, they just sing out loud, very loud. And I think it's more kind of like a distraction. So when Julian gets in pain, they kind of go off and do that. We don't call it musical therapy. We just call it singing.
That's it. You don't want to be your fun to always be treatment, right?
Sure, absolutely. You're right.
Great.
Yes.
And Darcy, I have a question for you as well from the audience about the biking video that you showed. It's wondering why does the cycling help? Does it chemically change the brain? Is it a distraction? What's going on in the brain?
It's a great question. I think it's multiple things that are happening with the cycling. So why we're particularly interested in this exergame project is that we know that when kids are having fun and doing something that they think is fun, they can fully engage in the activity, and so that's really important. The other thing we know about when we have children with cerebral palsy is that they have more difficulty moving, so they're sitting more, and that leads to sedentary behavior and poor cardiovascular fitness. And so if we can give an opportunity for exercise where we're boosting the heart rate, that can lead to, as we know from brain health research, a healthier brain, but it can also make us feel better. In this particular case for the exergames, children with cerebral palsy, after they've had orthopedic surgery of their legs, their muscles can be manipulated in the surgery, and it can lead to muscle spasms. And then you don't want to move the muscle, and that can make the muscle spasms worse. And then your therapist comes in and wants you to move your legs, but you don't want the therapist to touch your legs. You want to ignore the therapist. And so we found that the exergames and the cycling, the repeated motion of the cycling, can help to decrease the muscle spasms. Or that's what we're hoping to demonstrate.
Now, Christine, you've used a lot of non-traditional methods to do your work, you know, Twitter and working with parent groups like the Yummy Mummy Club, for example. Do other researchers take you less seriously because of that? Do you get dissed a bit, or have they gotten over that because of your success?
Yeah, well, I think I'm still definitely teased about it. And, you know, in my case, I've been doing this for a while, and it wasn't until I became a mom myself that I realized, like, my own kids weren't benefiting from the science that I had dedicated my career to, and that the traditional methods of getting the word out weren't working. So, you know, I think there's still a lot of skepticism, a lot of eye rolling, and I'll say a lot of hesitation on the part of health professionals to engage on social media. And I still hear health professional colleagues say to patients, like, well, don't go online to look this up. And I'm like, you're crazy. That ship has sailed. Like, of course patients are going to go online looking for health information. And so the question, I think, becomes more as health professionals, as researchers, what obligation do we have to make sure that good quality evidence is there when patients go looking, and making ourselves available to ask, you know, and answer questions. Because if we're not there, they're going to find somebody else. And we've seen who they'll find in the case of, say, the link between vaccination and autism. They will go to celebrity influencers who don't have the evidence. So I think we have to get over it and appreciate that this is how the world communicates and engages today. This is where patients and parents are going, and we need to be there.
Great. And we do have a couple of questions about patient engagement, and maybe I'll start with you, Darcy, on this. The question is, how are all you experts sort of engaging parents, allowing parents to interact and patients to interact, to trade tips? And in other words, how are they having a say in this?
Again, a great question, and I think we can always be doing a better job. One of the things at Holland Bloorview that we're really embracing is family engagement in all aspects of processes. And one of the important aspects of things that we do is in our Bloorview Research Institute, and we made a particular effort to get stakeholder engagement involved in all aspects of our research projects. So we have a stakeholder engagement team that's associated with the research project and provides guidance across the stages of the project. So that's just a little example.
And Donna, how important is that, interacting with other parents, and Julian interacting with other kids with cerebral palsy?
I think that's where we get a lot of our information from. I mean, speaking to what Darcy was just talking about with family engagement, I think we started being engaged with Julian, with Tom Chow, one of the big researchers at Holland Bloorview, and we've been working with him for years, and I currently am on a project with him right now, and you know, at every call-in, I'm there, and sometimes I don't say a word, and other times there's times when I can kind of provide like a family, you know, outlook on something, on how they're doing a study, on how easy it is for parents to participate and stuff. So I think it makes us feel like we have some kind of control over our children's outcomes, and that every step of the way, there's something that we can be involved in. And you're always learning something from both the clinicians and from the other parents too.
And another question for you and Julian. He's an adult now, he can communicate better, but as a child, how did he communicate that he was in pain? How did you know when he was young?
So even right now, he still struggles with telling us that he's in pain. I think one of the reasons is he doesn't want to. You know, with a lot of talk and discussion and talking to therapists, we've discovered that he feels guilty when he has pain. He feels bad that he is spreading this around the house. And so very often we as parents, me and my husband, know that he's in pain, and he will not admit it, and he won't allow us to help him. And that's one of our biggest struggles. Even more of a struggle than dealing with the pain is having him admit that he has pain and ask for help. So as an adult, I think that's only going to get worse, because he wants to be out and about, and he wants to be social, and he doesn't want to make other people worry about him and his pain. But as a child, before, he would just scream, like he would just cry, and that's the only way we would know that he's uncomfortable.
Yeah, I saw an interview with you where you mentioned sometimes you just had to wear earplugs and hug him. That's how you got through.
Yeah, yeah. That's right. So, I mean, for the first, I think, 2 years, I slept in the basement with him and just wore earplugs and just held on to him when he cried. And I mean, we didn't know at that point. I mean, I knew he was uncomfortable with something, but, you know, they would just say, oh, he's a preemie, you know, he has colic or whatever, and we didn't know what it was. But now I know that wrapped up in all of that other stuff was probably pain too.
Now, Christine, we have another SCIP question. How can SCIP be leveraged to improve care and getting money for things like physical and psychological services that are, as we know, are not covered by Medicare?
Right. So, I mean, it's hard for families to access a lot of the evidence-based treatments, and this is a major issue in pain management. And so, you know, really what we're going to be trying to do is working with the different stakeholders, the different groups, to first of all raise awareness around the value of these and what the evidence-based, I mean, I'm trained as a psychologist, and there's a very strong evidence base. And working at all levels, so within health institutions, but also outside the walls with policymakers. We have an event in Ottawa next week where we'll be, you know, informing and raising awareness about effective pain management, and certainly in the context of the opioid crisis right now, you know, pain and the importance of evidence-based pain management is, you know, plays a really critical role. So again, it's by bringing everybody together, raising awareness, making sure we share our evidence in powerful ways, and advocating for what we think needs to change.
And Darcy, we had a couple of mentions in passing of therapy. How important is the psychological aspect of dealing with pain?
I think it's critically important, and so there's different strategies that can be used, and one of the things that we talk about is not getting caught in that restriction in activities, and trying to go out and do your activities to help to take away that focus on chronic pain. And I think it's a really critical strategy, particularly for children, because they love to play and do activities. So something really, really important. I think there's always room to better study and understand and implement things like cognitive behavioral therapy strategies and mindfulness. And we were talking yesterday that this is something that we have no evidence for in children with cerebral palsy, but we would like to and are in the process of developing a research study
Great. So we're unfortunately almost out of time. So I want to, just before we leave, ask you to be inspired by Julian and give us each a take-home message. He cheated. He started with his take-home message. But Christine, what's the take-home message for improving? How can we improve pain in 30 seconds?
Yeah.
It's pain management, I should say.
Yeah, well, I think it's by working together. I mean, we all bring something to the table as the researchers, patients, different healthcare organizations, partners, and you know, thinking about how we can best work together, and through that coordination and collaboration, really make a difference for kids in pain.
And Darcy?
I'm going to take a different slant and put my researcher hat on. I think it's so important to continue to try to study these treatments, develop better treatments, try to figure out what's happening at a brain level. We really need new, different treatments for dystonia, for example, and that's going to come from translational neuroscience research. So I completely agree with your answer, but I'll add that on.
And Donna, what would you send people home with? What message?
I mean, I think, you know, I agree with both of what they have to say. I agree with what Julian says, to don't wallow in it. And I just want everybody else just to have patience with Julian when they see that he's in pain. You know, just to understand that it's going to take more time for somebody like him, that he still wants to be involved, that he enjoys all these things. It just takes some time.
Great. And I want to give the last word to Julian. He can remind me, what was his take-home message?
What was your take-home message again?
You end up in what the in a video that video of vortex of darkness.
So a vortex of darkness was the last words I heard. So I think it's don't wallow in your pain was the message.
Great. Well, and thank you all, and please thank you all for coming out. Please visit the booths out in the hall. Our speakers will be around to chat, and thank you again for being there. Thank you, Darcy.